Welcome to this lecture on adherence and retention within the continuum of HIV care. My name is Irina Eramova and I am a Senior Medical Officer of the HIV and Viral Hepatitis Program at the WHO Regional Office for Europe. This lecture will consist of three parts. We will discuss the effect of late presentation for HIV care on prognosis outcomes, cost and transmission, and explain the underlying conditions for adherence and retention in treatment and care. We will also describe healthcare system-related strategies to improve retention and care, as well as strategies for individual adherence support. Let's begin by discussing the consequences of late presentation and late enrollment in ART on prognosis outcomes, cost and transmission. In recent years, there has been a global focus on scaling up HIV testing services to achieve universal access to HIV testing, thereby universal knowledge of serostatus and early entry to treatment and care. Still, it is estimated that only about half of all people with HIV globally have been diagnosed, and there has only been a small advance in the CD4 count at presentation over the last 20 years. Late presentation or late enrollment in care, and consequently late initiation of ART, has significant influence on prognosis outcomes, transmission of HIV, and costs for society. Let us first define late presentation. Late presentation or late diagnosis is used when people are unaware of their HIV infection and not diagnosed until their CD4 count is below 350 cells per cubical millimeter, or have an AIDS-defining event, regardless of their CD4 cell count. Very late presentation is used when patients present with a CD4 count below 200 cells per cubical millimeter or have an AIDS-defining event, regardless of the CD4 cell count. There are three main consequences of late HIV presentation, enrollment into care, and late initiation of ART. Increased mortality and morbidity, increased transmission of HIV, and increased economic burden for health systems. In relation to the first consequence, numerous studies have shown that late diagnosis of HIV causes increased risk of acquiring co-infections and increased risk of treatment failure. Studies have shown that late presenters had a 6 to 13-fold excess risk of contracting AIDS or dying within the first year after diagnosis, and up to 1/3 of all HIV-related deaths are estimated to be consequence of late diagnosis. The graph showing the cumulative probability of death because of late diagnosis on the y-axis and time since HIV infection in years on the x-axis illustrates the increases mortality and morbidity associated with late HIV diagnosis. It is very clear that people diagnosed late with median CD4 cell count of 140 cells, as shown by the red line in the top, have a much higher risk of HIV-related death compared to those who are diagnosed at CD4 count of 350 cells, shown by the blue line. Earlier HIV diagnosis is thus one of the most important factors associated with better life expectancy. A study has shown that people who are diagnosed early are enrolled into care early and have access to life-saving ART, can expect nearly the same life expectancy as that of HIV-negative individuals. Further, the results from the START study demonstrate that starting ART as soon as possible after diagnosis decreases mortality and morbidity as opposed to starting ART after the CD4 count has dropped to 500 or 350 cells. Furthermore, studies have shown that antiretroviral therapy can reduce infectiousness, thus preventing HIV transmission. ART reduces the HIV viral load in the blood, semen, vaginal fluid, and rectal fluid to very low levels, so-called undetectable, hereby reducing an individual's risk of transmission. A decline of 96% risk of HIV transmission has been reported between early versus delayed initiation of ART, and reduced transmission has been confirmed by other studies. In terms of the economic burden on health systems, studies have concluded that medical expenses related to treatment and care of those people living with HIV diagnosed late are up to 3.7 times as high as expenses for timely diagnosis and treatment. Studies further suggest that HIV testing of any population group remains cost-effective as long as the undiagnosed HIV prevalence is above 0.1%. In this specific population, this will often include key population groups, including people with indicated diseases such as tuberculosis and hepatitis C. Despite the recent significant scale-up of ART in the WHO European region, ART scale-up efforts are not keeping pace with the annual increases in the number of people acquiring HIV infection. In 2014, UNAIDS set an ambitious target for starting and maintaining treatment for people living with HIV. By 2020, 90% of all people living with HIV should know their HIV status. 90% of all people with diagnosed HIV infection should receive sustained antiretroviral therapy, and 90% of all people receiving antiretroviral therapy should have viral suppression. While experiences to date indicate that these targets should be achievable in many countries of the world, enormous treatment coverage gaps persist, and too often people are enrolled in ART only when they develop symptoms of advanced HIV infection. Estimated ART coverage in 2013 was only 22% in the WHO European region. Access to ART is particularly low for key affected populations, like people who inject drugs, sex workers, and men who have sex with men. Intensive efforts will be required to increase access to and enrollment in HIV treatment and care for key populations, and efforts need to include a focus on early enrollment into ART, adherence to ART, and retention in care. Thank you for joining me for part 1 of this lecture. In the next part, we will discuss the underlying conditions for adherence and retention in treatment and care.